All right, good morning, everybody. Welcome to the webinar. It is right at 8, so we're going to go ahead and get started. My name's Kate. I'm a program manager at QCore that works on the Patient Centered Primary Care Institute. And I'm just going to go over a couple of logistical things and do some introductions as we get started. So we definitely want to hear from you today, and there's a couple of different ways that we're going to do that. Right at the start of the webinar, we'll do a couple poll questions, so make sure you are tuned in and ready to go to participate in those. We would also like to hear your questions about the presentation as we go through the presentation. So you can submit questions via the questions pane in the GoToWebinar control panel. You can also raise your hand. So right above where the arrow is pointing on the screen, there's a blue button with a hand on it. Sorry about the sirens if you can hear those. Downtown Portland. So if you want to speak up over the phone line, you can raise your hand, and that would allow me to recognize that you have a question and unmute your line. Do know that you would need to have entered your audio PIN in order for me to unmute your line. You can see that on the GoToWebinar control panel under the access code, and I can always send it to you if you raise your hand and I notice that you haven't entered that PIN. It's just what allows me to go ahead and unmute your line for you. So again, questions by either raising your hand or typing them into the control panel, and we'd be happy to read it out loud. One thing that I know we always get asked is whether the presentation will be available afterwards, and the answer is yes. So a recording of this presentation as well as the slides will be available on the Institute website by the end of business today. Before I turn things over to the presenters, I want to tell you a little bit about the Patient Centered Primary Care Institute. The Institute is a partnership that was launched in 2012 with the support of the Oregon Health Authority, specifically the PCPCH program, and it's managed by QCore. Through the Institute, we partner with content experts like the folks from ORPRN who are presenting the webinar today, and our goal is to get practices connected to technical assistance as they work on the PCPCH or medical home model of care. We encourage you to visit the website to access resources, including recordings of previous webinars, much like the one today. And there are also a series of online learning modules about the PCPCH standards and a number of other materials that you might find useful. As I mentioned, a key partner in the Institute is the OHA PCPCH program. The PCPCH model is defined by 6 core attributes, and under those attributes are standards that practices attest to become recognized by the state. You can learn more about the PCPCH program at their website, primarycarehome.oregon.gov. All right, I am so pleased to introduce our presenter, Dr. L.J. Fagnan from ORPRN today. Prior to joining OHSU, he was a general medical officer in the Indian Health Service in Alaska and a family physician in rural Oregon. His practice in Reedsport, Oregon, founded in 1977, was one of the 13 model rural practices funded by the Robert Wood Johnson Foundation's Rural Practice Project. In 2002, he was selected to start a practice-based research network at OHSU, which is the Oregon Rural Practice-Based Research Network, or ORPRN. Network membership in ORPRN includes 170 primary care clinicians and 51 primary care practices that care for 250,000 patients and are located in 40 Oregon communities. During the past decade, ORPRN has conducted over 20 projects studying elements of the medical home and have a lot of great experience in the topic of shared decision making. So good morning, LJ, and I will turn things over to you to introduce the poll question.
Great. I'm really happy to be here and talk about shared decision making, which really reflects the change in the conversation that occurs in medical practices these days, and particularly in the exam room. And you know, we've really had a big shift in what that conversation's like. And I wanted to get a little bit of information about making sure I can, whoops, I want to go up here. We've got some questions to kind of get an idea where you're at with this, and I'm assuming I can just, can I just go ahead and click on it and the poll question will come up?
We got it for you.
Okay. Okay, so here we go. So I want to talk about familiarity with the concept of shared decision making. We use a lot of terms like we've had evidence-based medicine in the past. This is another term, and I want you to check on this. And you've got 4 choices. I've never heard of it. I've heard of it, but I don't know much about it. I've read about it and understand the concepts, or it's a regular part of my practice. So please click on that, and we'll get a chance to see what your responses are here.
We're going to move through these questions pretty quickly, so it looks like we have a good number of people have responded, so we're going to go ahead and close that poll and share the results.
Wow, that's great. So people are, they're pretty familiar. This is really a big change in the last 3 years. Let's go to the next poll question. Do I do that, Kate, or is it?
No, we've got you. We're switching it over.
Okay, good. This is kind of fun. So how important do you feel shared decision making is in making medical decisions about taking a new medication, having surgery, screening for cancer? And so please check where this fits in terms of importance for you. We're going to see how quick you are. Wow, okay. So high degree of importance. Let's go to the next poll question. We've got 2 more. So which of the following statements about shared decision making do you agree with? Patients have a tough time understanding all they need to know. They're really not interested in it. There aren't good trusted sources of information. I prefer patients to rely on my recommendations, and there's not enough time for detailed discussions with patients, and you can select all that apply. You're not limited to just one.
And we'll give folks just a couple extra seconds on this one so they can really think about which check marks they want to make.
Yeah, this is a really cool question. I like it. Yeah, wow. This is really a lot to think about here. I think that framing the decision in a way that patients can understand is really critical. I do, we obviously see that most patients are interested in sharing a decision. It sounds like there are trusted sources of information. Most people like to be in partnership with their patients, but time is a huge issue. So thanks. Let's go to the last question. I thought we did that one.
Oh, that one is just, it's the same, but what do you disagree with?
Oh, okay, here we go. Okay, so yeah, so go for it.
Okay, so they think we think we might have had a technical error on that one because we launched it and we went back. So
let's just go ahead and go on with
thank you.
With things. Can I get that next slide up, Kate, or will it?
Yes, you can advance it. It's just taking a second to load up.
Okay, okay, got it. So while we're getting ready to do that, I think one of the things we're seeing as I think shared decision making is a nice way to frame what's going on in the exam room. That much of what we do in the exam room involve medical decisions, and they involve value judgments, and who better to make those decisions than patients. And this is where we're going to go with talking about shared decision making. And I could probably pull up, oh, here we go, good. So maybe it just takes a little bit of time, Kate, to move from.
Yeah, so you should be able to click it and move it to the next one.
Okay. And so I'm trying my best to get to the next slide. Here. There we go. So one of the things that is foundational here is that there's a lot of uncertainty in what we do in medicine these days, and that there are general principles and some general knowledge, but it comes down to the individual patient, and that individual patient has some unique characteristics. But what we find is that a lot of the care in the past has been doctor preference care, and that's been documented well in the Dartmouth Atlas, whereas in certain parts of the country, people will get a lot more back surgery than other parts of the country. And so it's really not necessarily based on evidence, but is based on what the standard of care is from the physician standpoint. Increasingly, we're finding that much of what we deal with in the exam room fall into this bucket of preference-sensitive conditions, where there's more than one option. An example is knee osteoarthritis, what to do about menopause, cancer screening, management of diabetes, and a very common one for the older population, particularly those that are sick, or end-of-life decisions. So this is what we call the gray zone of decision making. And you can see that there's a little bit of the area where there's things that are harmful, and there's some 11% beneficial. And the rest of it is really the gray area. So only about 14% of it we can say, yeah, we really kind of got a pretty good handle on what's likely to happen, and so shared decision making may play less of a role. But this is looking at 3,000 commonly used treatments. So as we talk about preference-sensitive conditions, I mentioned that there's uncertain or no clear evidence supporting one test or screening or treatment option over another. That there are different risks and benefits for each option, and patient values are important in optimizing decisions. And patients, there's some patients that are risk averse. There are other patients that, man, they kind of want to have everything that modern medicine has to offer. So there's a lot of variation there. And so part of our job is understanding who they are. An example might be knee osteoarthritis. So here's a patient that has knee osteoarthritis in the inside part of the knee, some joint space narrowing. And these are some of the options or choices that the doctor and patient are faced with. You know, gee, if you did some exercises and lost some weight, your knee pain might not bother you. It's not going to change the x-ray any, but it might make things better. There's pain medication. Injections can be helpful. Complementary therapies have got less support, but oftentimes people find themselves in the operating room. And so the role of arthroscopy and osteotomy and knee replacement is unclear and very much influenced by the individual patient. Another example is early stage breast cancer treatment options. Women are faced with decisions about what to do. You know, do I have a lumpectomy? What do I want to do about breast reconstruction? Radiation versus chemotherapy comes up, and so there's conversation to be had around those decisions. And shared decision making is a nice approach to that conversation. I like this figure, which is almost 20 years old, and it's informing patients. You're going to see this thread run through the conversation today. I'm always impressed with how much more thought we give in terms of preferences and what we want to do to decisions such as buying a new car than we do in terms of deciding what do we want to have done in terms of having a surgical procedure on our hip. But this cartoon says, do I know the potential benefits? Do I know the potential harms? What are the likelihoods of those outcomes? And do I know the consequences of my decision? And so shared decision making is about that conversation that gets at addressing those issues. Oftentimes in the exam room, we spend a lot of time thinking about what the diagnosis is. The diagnosis is incredibly important, but I think equally important is really what do the patients want to have happen. And far few clinicians aspire to the same standards of excellence in diagnosing patient preferences as they do in figuring out what the diagnosis is. And so that skill set is really not there for many clinicians and needs to be developed. It's been written about a lot. That second reference actually deals with a study of patients ages 80 years old older that are high risk of dying in Canada, and less than a third of patients had spoken to their family physician about their preferences before hospitalization. And only 1/4 of those recalled being asked about their preferences or advance directives as they entered the hospital. As a result, 70% of physician orders concerning resuscitation and intubation were really totally discordant with their wishes. And it's hard to find that documentation in the charts. So there's this silent misdiagnosis. We're really not being explicit about what patients want to have happen. And there are consequences to decisional conflict and not figuring out where patients are at. They're 59% more likely to change their mind. We find that 50% of folks that are scheduled for screening colonoscopy fail to show for the appointment. They may delay the decision. They may have regret or fail to not be really aware of what the evidence is, and may blame the clinician for a bad outcome, because their competing actions involve risk, loss, regret, and challenge to personal values. And they're tools to measure decisional conflict. This is one tool that I like because it's simple, and Annette O'Connor and François Garay have used it to measure, to question patients about, we're studying chronic obstructive lung disease and we're incorporating shared decision making. We want to know how that conversation was for you. And they created this SURE tool. Do you feel sure about the best choice for you? Do you know the benefits and risks of each option? And are you clear about which benefits and risks matter most to you? And do you have enough support and advice to make a choice? I like this tool because it's fairly simple to use if you really want to figure out whether or not shared decision making is happening at the visit level. So I want to talk a little bit about the patient's role in decision making, but I want to first cover what are some of the essential elements that may occur in the office. So you reach a decision point. You talk about the problem, you present the evidence, you address the uncertainty, what are the benefits, likely benefits, what are the potential for harms. Gee, what do you want to have happen here? And what do you think is really possible for you? And very importantly is, what does the clinician recommend? And clinicians, the patients want to know what their clinicians recommend and what their experience has been. Clarifying, understanding is really important. An example is, I want to be sure I've explained things. Please tell me what you've heard about what we decided to do about this. And oftentimes patients and the clinician may defer the decision and walk out of the exam room without a decision. That's okay, because folks often go home, talk to trusted friends or family members, and need to think about it for a while. And then, but it's important to close the loop and arrange for follow-up. So we're really fortunate to have two patients kind of share their perspective on shared decision-making. And Sally Morgan and Linda Deerdorf. And interesting enough, they're both teachers. And we all know that patients are our teachers for those of us that are in medicine. So I'm just assuming that Sally and Linda are extending their teaching capabilities. Sally has a Bachelor of Science degree in education and a master's degree in geriatric counseling. So she's active with the Samaritan Lebanon Hospital. And Linda Deerdorf is in Reedsport. She and her husband Jim have been longtime teachers and now really make some cool furniture. I'm really kind of have a little bit of bias because Linda taught my daughter and her husband Jim taught my son in school, so I'm glad they're here. And so, Sally, I wonder if you would just kind of share your perspective about what shared decision-making's been like for you in terms of your medical care.
Hey, good morning. Mine is a different take. As the doctor, the surgeon that I went to, uses this shared decision-making, and I'll go through that process. This is the first time I met him. I walk in, and the first thing he does is shake my hand, and he doesn't use the computer, which is very important to me because I feel then he's paying attention to me. And he sits across from me at a small table so I can see what he's writing, and he looks me in the eye. And then as he works on my shoulder, because it was for my shoulder, he explains the different types of options we have, the MRI, going to therapy, and we talk about what that involves. And then when he recommends the MRI, he doesn't push it, but again, we talk about the pros and cons. When we talk about surgery, he asks me questions about what I know about the surgery, and if I say no, he explains it. He explains the therapy and how long until I can use my shoulder. And he listens to all my questions and concerns. And I have come up with some really interesting questions, and he's always able to answer them. When we are through, then he comes up with a plan, and it would be the MRI. And depending on what's happening with that, and then it would be surgery, and we went through that. He shakes my hands and walks me partway down to the exit. And throughout the appointment, he asks questions about my life. Where do you live? Where did you go to school? Do you have pets? That kind of thing. And he laughs at my jokes, which is makes me feel good. And when I leave, I'm feeling better than when I came in. I feel a little more hopeful that my shoulder is going to get ready or get better. And I feel he understands me. And the most important thing about all this is I feel like I'm valued by him, like I'm his only patient. And so that's my surgeon and the way he talks to me and helps me through the problem.
That's great, Sally. I got this real vivid image of that partnership. Wow, that's powerful. So as you listen to what we're talking about here and you have questions, jot them down. Feel free to raise your hand because this this is supposed to be a bit interactive, and it's kind of like in the classroom. So let's turn to another teacher and hear from Linda Deerdorf.
Good morning, everyone. I, too, have been really fortunate to have had medical providers over the past 35 years or so that have not only believed in but actually practiced what we're calling shared decision-making. I didn't realize that's what it was at the time over those many years, but when I had decisions that needed to be made regarding, treatment or procedure, I'd say about 99% of the time my various healthcare providers used that shared decision-making process. We always discussed, the medical professional would discuss various options and procedures that he or she was knowledgeable about, and we would always talk about the pluses and minuses. So the discussion was always there, almost always, and then the decision would be made mutually on how to proceed. And I always felt comfortable with that process. I felt like I could ask questions, and that I was a part in an active participant in the decision making. I can, however, think of one instance, and I had to think pretty hard over the years, where I believe one step in this process we skipped. And I think as a result of that, I've thought about it over the years, I think we ended up with kind of a less than desirable outcome. It happened when I was 55. I went in for my annual physical, and we talked about the need for colon cancer screening. And again, different options were discussed, and my physician, presented them, and we did some plus and minus a little bit. And I remember the physician saying that although colonoscopies were considered the gold standard, I didn't have a history of colon cancer in my family. And so the recommendation was to go with a sigmoidoscopy and another procedure. Well, in my mind, when I went in, I was thinking, colonoscopy, that's what you do. So that was my preference based on my little bit of research. And actually, like most people, I would rather have, just given them all a miss, but knew I couldn't go that route. So after all of it, I ended up having the sigmoidoscopy and this other procedure. And I think because, in retrospect, I realized that the step regarding my preference and why I preferred the colonoscopy, we just kind of skipped. And I ended up having a colonoscopy shortly after these other two procedures due to some issues that came up during the procedures. And I guess, again, as I think back, I probably should have been more assertive in stating what my preference was. I think mutually we probably would have come up with the colonoscopy procedure rather than going the other route. I'm not sure. But the outcome ended up kind of resulting initially in a waste of time and resources, and we probably could have avoided it if we had just implemented that one step of talking about my preference and why I had that. But I believe the shared decision-making process, it really ensures that the patient has to take some responsibility in his or her care, and that should result in a more positive outcome. Rather than simply being told by your provider what's best for you, the patient in shared decision-making has to take some ownership in that decision. And I think then the individual is more likely to follow through and be happier with the result. That's been my experience, and I know as an educator, when you involve your staff or teachers in any decision making, the result is usually superior. So I think shared decision making can be applied to many different facets of life. But that's my experience.
Great. Well, thank you, questions that folks have, feel free to weigh in here.
Hi, there was a question written in. I'll try and summarize it a little bit, but that there are patients out there who look to, or how do you, or what do you have to say about patients who are out there who look to their physician to guide them and direct them and don't necessarily want to engage in deeper conversations? They want to be told what to do.
Yeah, that's a comment that we hear a lot about, and oftentimes I'll say, I understand you want to have my input, but I'd like to learn a little bit more about kind of your thoughts about this. And so I just kind of bounce it back to them and say, what do you understand about this? Tell me a little bit about that. And so it does take a bit of time, and for some patients there's a shift in what that conversation's like, and we need to make room for the patient experience and voice, much like Linda just outlined there. So it's a common refrain. I'm not sure how prevalent it is. I think it's increasingly patient autonomy occurring, and the balance of power is shifting away from the physician to the patient. I saw a New York Times editorial, or not, just a column a couple weeks ago that says, "Doctor, the patient will see you now," and so it's shifting. And so I want to talk a little bit about making room for that patient voice. The Informed Medical Decisions Foundations, which is part of HealthWise now, has some really nice language just to think about, as we invite patients to participate. And so, I like scripts a lot. And so as you work with clinicians and staff, it's helpful to say, well, what do you say? Well, there's a decision to make about your treatment or testing, and I'd like to make it with you. Knowing what's important to you will help us make a better decision. And then the other one deals with uncertainty. Sometimes things in medicine aren't as clear as most people think. Let's work together so we can come up with a decision that's right for you. Here's a couple more things that I like as we're trying to figure out where patients are coming from. Considering what we've discussed, do you have a thought about where we go with this? Do you need more time to think it over? Do you need more information? Well, what's the hardest part about deciding? This is how to get at where patients are at and not assuming that you know where they're at. We know that shared decision-making goes a long ways to meeting the triple aim of improved health. There's more optimal management of chronic illness and prevention. The patient experience of care is enhanced. They're empowered. They're participating in decision. And we find that people that go through shared decision-making, when they're able to explore all the options, often opt for less invasive and expensive care. We have ways of measuring shared decision-making, and we're working with the Oregon Health Authority in trying to figure out, does shared decision-making happening in the practice? And there's a set of questions here that I'm not going to read through, but it kind of just gets at, did we really ask you about what matters to you about the pain that you're experiencing with your knee and what you want to do? Did we discuss the options with you? And I like this one. This one gets a little bit at Sally, this 43H. In the last 12 months, how often did this provider make it easy for you to ask questions or raise concerns? What I heard with Sally's presentation is her doctor treated her as another human being and not just a patient that's on his or her schedule. and getting through the day. So it's really about that partnership and feeling like you've got somebody that's trusted. So I'm going to talk a little bit about some key messages here. And again, please kind of share your thoughts about whether or not this fits or whether it's...
LJ, we did have one question if you want to take that before you move to the next part.
I do.
Okay. So it's doctors often worry about knowing how to juggle all the statistics and helping patients make decisions based on math. However, both the patients who spoke, both Linda and Sally, indicated that the process and the human contact was more important than the numbers. So this person was hoping that, LJ, you could speak to that, and maybe the patients could comment on that as well.
Yeah, so before I start, Linda or Sally, do you have thoughts about that?
I guess I would just go ahead, Sally.
No, go ahead, Linda.
Okay, I would just say that I always want to hear, you know, from my medical professional what the options are and what their thinking is, because they're up on the most current information. But after that, then I think is where the discussion takes place and where you start getting down to, you know, really talking with the patient and getting their preferences and their thoughts and their thinking. But initially, I think most people want to hear from the professional what they know.
I agree. And I don't care about statistics or numbers or anything like that. I want to know what he knows or feels should happen, and then to discuss it with me as a person. I agree again with Linda that they have the knowledge we don't, but it's important that we discuss what they know, what the doctor knows.
Yes.
Well, thank you for those comments. I was just looking at the scripts. I mentioned the scripts earlier from the Informed Medical Decision Foundation, 6 steps, and I like this one in terms of checking for understanding. You've seen a lot of numbers which can be confusing. Do you have any questions? May I help sort through them? And so it's a matter, again, of that partnership of understanding the numbers. And we've got fancy things about talking about relative risk and absolute risks. That numerical literacy can be a problem both for the doctor and the patient. So that's a challenge. Kate, any other questions before I move on?
That's it for right now, but just remember, folks, you can write in questions through the control panel, and we'll take them as we go.
Great. So I'm going to talk about patient-shared decision-making behaviors. You know, somebody can kind of, if they were to video, we here, we're in a teaching place here at the medical school, and so we will videotape encounters between the resident and the patient. And we can find that shared decision-making behaviors can be observed. They can be modified. There are tools out there, some of which are articles that are in paper. They're on the web. There are also videos that can enhance shared decision-making. But they're heavily influenced by clinicians' attitudes. So the clinician making space for the patient is really important. So from the clinician standpoint, the same thing. When we look at those videos, we can see are these shared decision-making behaviors happening? And they can be enhanced by decision support tools and training. The 2 most critical aspects of shared decision-making are going back and assessing the patient's values and preferences. What do you want to have happen? You're having a lot of back pain. You know, what do you want to do? And patients will, you know, and oftentimes the doctor will think, well, they want a prescription for a narcotic. And so I will say that, and the patient says, you know, one of the things I like to avoid, doc, is medicines. And then I realize, you know, I didn't have a clue about that. I want to figure out how I can exercise and improve my pain. and the screening for decisional conflict. You know, I'm not sure I want to put up with that risk of having a colonoscopy because I've heard that you can have your colon perforated if you have that. I think I'd just soon do the stool test. I know I've got to do it more often, but that's what I want to do. And so people are sometimes conflicted. They're not sure what to do. So in the United Kingdom, they have this ask 3 questions, and I think I showed you that pie diagram before, where most of what we deal with in medicine, there's some degree of uncertainty. So these questions play a role in most of the visits that patients make to our offices. And when you face the choice, you say, well, the patient should say, well, what are my options? Well, what are the possible benefits and risks? And how can we make a decision together that's right for me? I have a little bit of that image that Sally described of the doctor walking her down the hall to the MRI, and the two of them having this, this conversation. So again, these ask 3 questions. What are my options? What are the benefits and risks? And how do we make a decision to move forward? What does a doctor need to know about the patients? And so, as I mentioned, some patients are risk averse. Others want everything that medicine has to offer, but there are also consequences to that. An example is we know that people that have imaging for low back pain, that there's a direct correlation between getting an MRI and the likelihood of ending up on the surgical table having a procedure that may not have the best evidence to support it. So we think there are better outcomes from shared decision making. I like this mantra that's at the bottom. And I think if everybody had that in their exam room, the conversation, the shared decision conversation would happen a lot more. No decision about me without me. I just think it's a better model of care, and it's where we're heading. And I know that we finished a bit early here, but I hope that some folks will share their thoughts about this. We wanted to leave some time at the end for people to share their experiences about shared decision making, either what's working or how do you start, or what's not working.
All right, just a reminder to go ahead and type in questions through the GoToWebinar control panel, or if there's a brave soul that wants to ask their question over the phone line, you can raise your hand and I'd be happy to unmute you. We do have the last 15 minutes or so to take questions, and we'd really like to hear from you. One question that came in was about time. So how do you, and we kind of saw that in the poll questions in the beginning, as people are feeling really strapped for time, what do you have to say about how these kinds of practices can be integrated when time is such a struggle?
So I'm hoping somebody's going to help bail us out and kind of give their experience rather than have me talk. So does somebody have some experience or thoughts about how to address that barrier, which is really a very common one when we talk about this?
So if you want to be the brave soul who answers this question, you can raise your hand and I will unmute your phone line. Some of you indicated that you do this in your practice in the poll at the start. So sounds like we might have some people with some expertise to share out there. While you're thinking about what you're going to say and warming up, there are a couple other questions that I'll just read out so that people can chime in on any of those too. One of them is that they see physicians struggle with patients who want opiate treatment as the only option, and PCPs feel backed into a corner. And then another question about suggestions on where to find good shared decision-making tools.
So the one question about opioid use is it is a real challenge, and I know that there are tools out there to help share with patients the benefits and risks, and oftentimes it doesn't happen over a visit. It may happen over a period of time, and it may take, just like stopping smoking. There may kind of be multiple efforts at trying to cut back on your narcotic use, and just kind of sharing the evidence and going to the well. Looking at shared decision-making tools, there are some good resources, and I think, Kate, one of the things that we might put up there is the toolbox that we developed on shared decision-making, which is a web-based toolbox, and there's a whole section of resources there where folks can find shared decision-making tools. The Informed Medical Decisions Foundation that I mentioned earlier is a great resource, and there is an inventory that's maintained at the Ottawa Hospital Research Inventory, or OHRI, that has an entire inventory of shared decision-making tools, and so we should put that on the Institute website. Those
yeah,
resources.
I think there's some resources already linked. We'll make sure they're easy to find from the webinar page. So folks that are asking about resources, we will gather up some, and we will link them right from the webinar page to make them easy to find. And so if you visit tomorrow to check back for those, that'll be good. So there's been a number of other people writing in, but no souls that want to speak up on the phone today.
Well, let's go with some written questions.
Yeah, so someone wrote they'd like to hear about how other staff members, medical assistants, receptionists, nursing staff can help with shared decision making, given the questions and the concerns about provider time.
Yes.
And then someone else wrote in just kind of speaking to that. So I'll read that, and then maybe LJ, you can add to it. One person wrote in to share that they have 2 people check prior to the provider to make sure that the provider is not wasting time if a patient's had a colonoscopy or if they need it, so that they scrub charts basically to make sure that patients who do need different tests or treatments are brought to their attention, but they're not searching around for it if they've already had it done. And that way they can go right into the shared decision-making discussion without having to search through the chart. And so the time saved from that allows them to have more in-depth conversations with the people that they do need to talk with. So I don't know, LJ, if you have any more you want to add to that.
Well, what I want to add is that's a great question, a couple of questions there. This is really about an entire practice-wide approach. It's not about just the doctor in the exam room with the patient. I know oftentimes many of my patients find it easier to talk to my medical assistants about things than initiate the conversation. Some people have that relationship with who answers the phone at the front desk, and so it's really important that everybody in the practice be trained in what shared decision making looks like. And I like what's been described there about preparing for a visit. So oftentimes we have this concept of a planned visit, and that is looking at somebody that's coming in, what do they need out there that hasn't happened, maybe in terms of cancer screening, say mammography, and so providing them information about allowing them to make a decision to do that ahead of time, so that when they enter the exam room, they're pretty well prepared to make that decision. Some decisions are best made through a conversation with the doctor in the exam room because there's some clarity that needs to be brought in that's going to just take that one-on-one conversation with their doctor. So there are different approaches, but teamwork plays a huge role in making this happen in practice.
This is Kate. I'll jump in just with two things. One, we did have a brave soul. So David, I'm going to unmute your line momentarily for you to ask your question. But before I do that, just a few weeks ago, the Institute hosted a webinar on scrubbing and huddling. So part of what teams can do to help prepare for visits. So to the point that the attendee made about scrubbing and how that saves time and allows for these conversations. If you want to learn more, you can check out that webinar. So David, I've unmuted your line. Are you there?
I am here. Thank you, Kate.
Yeah, go ahead.
Thank you for the presentation. I found it very interesting and timely to a lot of the work that we're doing around Oregon. My question involves the cost of care, and with the increase of high deductible plans and increased out-of-pocket costs for patients, if there's effort from medical providers to speak to patients about what cost of treatments or cost of possible medications might be versus the efficacy of those treatments and medications. And I'll use myself as an example. I had an injury to my foot, and I had an option of getting the bone repaired or doing some physical therapy, and it was very hard for me to find the cost of those two options I had. I eventually went with the surgery, and it did cost me a significant amount of money. So I was wondering if there's cognizant on the medical end of what that can cost to the patients, and having discussions with the patients about those costs.
I certainly think that's got to be a part of the conversation. I've been impressed with how little that's addressed in shared decision-making tools with regards to a given condition. And it's really, quite honestly, represents a gap in the conversation that we have with patients. Yet it's a huge influence on the decision that's made. And so it's kind of the silent part of the conversation. And I don't know. Sally, Linda, you have any thoughts about that as patients?
I'm just thinking that maybe part of the reason the discussion doesn't take place is because the medical provider doesn't want the patient to feel like they're not worth it if they would present a cheaper version of therapy. I don't know. It's true. It is rarely discussed. At least I can't remember talking about cost of different options very much. But it may be because nobody wants to feel like they're not worth the more expensive route. I'm not sure.
Well, my primary, when she switches medication on me, she always checks the cost and lets me know which is the benefits compared to the cost of the medication. So she will tell me that this medication is $100 a month compared to $50, and then we discuss what the benefits are.
That's great, Sally. And so I think you got a great primary care provider doing that, and so I like that approach. And I think one is I think Linda's point is we don't want to be promoting the lower cost option, but we want to kind of say are you aware of what the costs are of the various options? And
yes.
is that going to play a role in your decision as to what you do here? And so I think we need to kind of reflect it back to the patients and assess it. And so I get a lot of patients saying, no, I got great insurance. Cost is not an issue for me. And I have other patients say, yeah, cost is a big deal, and I'm not going to have the colonoscopy because I can't afford to have to pay the copay or the deductible.
All right, so there were a number of other questions, and those of you who we don't get your question answered specifically, we will follow up via email with some of you. and especially about the resources. We'll make sure folks who have asked about those get connected to that stuff. So someone else, there were two other points that I think maybe in the last 4 minutes we might be able to touch on. The first is, what if you go through a shared decision-making discussion and a patient chooses an option that you simply don't think is the best thing for their overall health? And so how do you deal with that is the first thing. And the second question is that it's clear that shared decision-making is important, but people are really struggling to identify tools that are considered accredited or validated, and then documenting their use in their electronic medical record. So if there are any comments about how folks are documenting these kinds of conversations, that would be helpful.
So Kate, the first one was about making a decision that the physician might not be comfortable with, and so I think physicians are part of the conversation too, and say, I hear what you decided, but if it's okay, I just kind of like to share kind of my thoughts with you about that. I'm comfortable because I've been aware of adverse event A happening this amount of time, and I just want you to be aware of that. But the ultimate decision maker is the patient. The only time that doesn't play a role, obviously, is if you're in a critical life situation. Decisions are made without shared decision making, oftentimes, and but at others, it's medical. I like this statement: medical decisions involve value judgments, and who better to make those decisions than patients? But I think physicians have an obligation to kind of share their thoughts and perspectives as well, and make that a part of what patients have as their information base to make their decision. And then the last comment I'll make, because we're near the end of time, is sources of decision aids that have evidence behind them as being effective. There's a standards committee for shared decision making, and you'll find that also on some of those websites that you're going to see posted on the Institute as part of this webinar. We'll make it available because there is a standards committee, and it's a lot better than just kind of searching the web and looking for what do I do about herniated disc. There are places to get some really good decision tools elsewhere. So Kate, we should wrap her up.
Sorry, I was on mute and talking to no one. So yeah, we are going to go ahead and wrap up the webinar. So there's some references on this last slide. Please do take the survey that will pop up after you close out of the webinar today. And then like we promised, we'll follow up individually with some emails to folks who have more specific questions. We'll make sure that the resources that people can access online are posted to the webinar page, and we'll make sure we get that done by the end of the day, along with the slides and the recording. Thank you so much to our presenters and for sharing their time with us today. Linda and Sally, we appreciate you getting up super early and sharing your experiences with us, and facing the technology, which can be daunting. So we really do appreciate that, and we hope everyone has a great day.
Thank you.
Thank you.